Thank you, Tony. That was outstanding. If you could hang on with us a little bit till the rest of the talks or the break. That you just went through a 20-year journey in 20 minutes, so we appreciate that. But I think you made some great points, which is I think most of us now consider TIVA our first approach whenever possible. Our next speaker is Dr. Michael Singh. Dr. Michael Singh is one of the co-directors of our Aortic Center. He is one of the few physicians I call at least once a week when I have questions about patients or somebody to talk to. He's an outstanding surgeon, an outstanding partner, and just a gentleman, and a pleasure to always work with on a daily basis. So excited to hear his perspective on this. Thank you, Mike.
Eves, thank you very much for the kind invitation to present. And I agree with what we just heard from Tony. I think without question that endo and open truly are complementary to one another, and I think this presentation will be a nice dovetail from what we just heard. So few aspects of vascular surgery have changed more in the past 2 to 3 decades in the management of abdominal aortic aneurysmal disease. And it starts back in 1990 when the first EVAR was performed by Dr. Juan Perotti, and then he published a series in 1991 of 5 consecutive cases. Remarkably, in that short period of time, EVAR really has become, I think most people say, the standard of care for abdominal aortic aneurysms. And indications for use have continued to expand since then because of improvements in technology, imaging planning, physician experience. But despite these changes, there are arguments for and against EVAR to this day. So if you think about this paradigm shift beginning in 1990 with the first case being performed with a relatively primitive graft, it was a tube graft with balloon expandable stents at the top and the bottom, and was placed in a very unique abdominal aorta. Where are we today? Well, just as Dr. Estrella told us, we've made remarkable changes. Technology has advanced, and look what we can do today. We can effectively treat the thoracic, arch, thoracoabdominal, and abdominal aorta with an endovascular approach. So this is quite unique. Well, I'll tell you what hasn't changed. Aneurysms haven't changed. We still have infrarenal, we have pararenal, we have paravisceral aneurysms. What has changed is that the endovascular surgery has evolved. We've introduced disruptive technologies, EVARs, FEVARs, TVARs, BVARs, PMAGs, so on and so forth. And this has been motivated by the following: advancing technology, the industry itself, favorable reimbursement, in addition to patient preference. And in turn, it's catalyzed the creation of innovative technology, hybrid endosuites, intraoperative imaging, less invasive endovascular therapy, along with large bore percutaneous access. So if you look at publications for abdominal aortic aneurysms, it began back in 1950 when the first open repair was performed by Charles Dubost in France. And if you look at the trend going upwards to where we are today, it's almost identical to what we see with EVAR, although EVAR started 40 years later. So as we look at national trends, this is an interesting finding because I want you to focus on the red arrow, which is the inflection point. So if you look at national trends of both open and endovascular abdominal aortic repair, the inflection point is in 2015. And this is a significant finding where the paradigm shift really occurred. And what you'll acknowledge is that the number of EVARs exceeded the number of open repairs in a relatively short period of time. And if you think back, it was only in 1990 that the first endovascular repair was performed. So in 15 years, a lot occurred. Now I need to reflect back on the history and look at some of the more landmark randomized control trials when we're looking at EVAR versus open repair. EVAR 1, DREAM, OVER, and ACE trials. And for the most part, the main findings were very similar. We note that with EVAR, there are better 30-day outcomes. The early survival benefit of EVAR probably is lost anywhere from 1 to 3 years after the initial implant. We acknowledge there's a higher aneurysm-related mortality in the EVAR group after 8 years, and this is very interesting, and that there's a higher reintervention rate following EVAR, and that's not unexpected. So if you look at this meta-analysis systematic review, they took 7 of the largest randomized control trials with over 2,900 patients. 3 trials had long-term follow-up. Interestingly enough, 12 to 15 years. So that really does represent long-term follow-up. And within the meta-analysis, you can appreciate EVAR early on seemed to be doing very well with a lower 30-day mortality. However, beyond 8 years, the aneurysm-related mortality was higher with EVAR. And this is where some of the controversy currently is. When you look at their forest plots, it's quite interesting, and I put all 4 on there. The top being the aneurysm-related mortality with a hazard ratio from 0 to 6 months. The second graph, 6 months to 4 years, and then as you work your way down from 4 to 8 years and beyond 8 years. And what you'll acknowledge is that the hazard ratio clearly shifts from favoring EVAR in the first 4 years to what favors open repair beyond 4 years. So with that information, the society guidelines have been revised as recently as 2018 for Society for Vascular Surgery, and there are some things that I think most of us will accept. Repair for men typically should be considered when the diameter of the aneurysm is greater than 55 millimeters. For women, greater than 50. For people who have anatomic suitability, we recommend EVAR for ruptures. I think that's appropriate. And then when you look at the volume of annual usage to make sure that your outcomes are comparable, the minimum at a center of excellence will be 10 cases and expected mortality of under 2%. And this compares very favorably with the 2019 European guidelines, once again noting that for men, typically the cutoff is 55 millimeters. For women, 50 millimeters. Their recommendation, number 60, notes that in patients with suitable anatomy and reasonable life expectancy, EVAR should be considered as the preferred treatment modality, and that aneurysm repair should be considered in centers with a minimum yearly volume of 30. As I mentioned, the SVS guidelines noted 10. So here we are, 2023. There's a wide range of devices that are available, and what we've acknowledged is that there's new devices being introduced, current devices being modified, we have better deployment mechanisms, we have devices that are specifically created to match the anatomy of patient, we have lower profiles so they can be done percutaneously, and really the goal is to give us the best result, the best durable result, which is more important. And inherently, one of the Achilles heels when it comes to EVAR happens to be the infrarenal aortic neck. And we will acknowledge that about 35% of patients undergoing EVAR have some type of feature of an adverse anatomic neck. They may have short necks, broad necks, angled necks. They may have aortic necks that have thrombus, calcification, or reverse taper. And with that, skepticism exists about the durability of EVAR in these situations where we're putting a device in outside of the IFU. What happens when you do it? Well, you probably get away with it at time 0, but over time, we end up having more adverse events than we truly want. You have the endoleaks, the aortic sac enlargement, migration of the device, and heaven forbid, the aortic rupture. Now, this isn't device specific. It probably is a combination of anatomy and clinician judgment. So let me give you a case. 72-year-old male, history of coronary disease, hypertension, 62 millimeter AAA, so the criteria are appropriate for repair. CT imaging shows that you've got a fairly angulated infrarenal aortic neck, probably a little barrel shape, and based on the measurement 32.1, it's a little bit larger in size. So this anatomy, as I just mentioned to you, falls outside of the instructions for use based on all of the EVARs that are available in 2023. It's a large neck, it's barrel-shaped, it's angulated. An endovascular temp was performed with a 36 millimeter bifurcated device. There's a fairly impressive endoleak after the device was placed. So a cuff was then placed, which extended it to the renals a little bit closer. Unfortunately, the end result was the same, and it was expected. It was predictable. There was a big 1A endoleak necessitating open repair down the line. So these types of interventions, although you can do them, doesn't mean that you should, because success isn't based on the results of your intraoperative finding. Success is how the patient does over the prevalence of the implant. And now we've got ample evidence clearly linking hostile aortic necks with type 1 endoleaks and an aneurysm-related mortality of 11% at 3 years. So beyond the anatomy, why do these EVARs fail? Why is there still debate about EVAR versus open? Well, it's a combination of things. Yeah, there could be some device factors. You're not choosing the right device to match the anatomy of the patient. I already told you about the aortic neck. Degenerative necks, diseased necks, challenging necks probably aren't going to have a favorable outcome. Technical misadventures happen to all of us, and sometimes unexpected, sometimes expected, but probably the area of greatest opportunity is judgment and planning. And I think this is one of the areas that we really need to focus on moving forward, that with sound judgment, working within the IFU, in turn, we probably can have better results than what we're seeing. Well, to manage some of the inherent challenges that I just talked about, the anatomy, there's a variety of versatile branch devices out there. And Tony had mentioned some of those previously. Some of these devices are off the shelf. Other ones are custom made and patient specific. Very few of them are currently available, and most of them we are able to have access either through IDEs or for industry sponsored trials. And the one device that currently is available in the US is the Zenith Fenestrated Endograph made by Cook Medical. And with that, their original study, 67 juxtarenal aneurysms were treated with a Z-Fen device, including 178 visceral vessels, and these are patients who were treated with fenestrations or scallops. Technical success was excellent, 5-year survival was very good, and target vessel patency was excellent, 97%. And with that, the FDA approved it in 2012. And certainly this device expanded EVAR eligibility with good midterm survival. And as you look at the arrow in red, basically what's showing you is that we're able to advance our landing zone cephalad, so in turn we've got a better seal and a lower risk of endo leaks. Upcoming is going to be the Z-Fen Plus trial, which will give us more access to additional fenestrations and or scallops. The Gore-Tanby trial came out with a feasibility study. We were part of that trial. There are 11 patients with pararenal type 4 thoracoabdominal aortic aneurysms, 52 branch vessels, high technical success. And what was nice to see is at 30 days, there's no mortality, no rupture, spinal cord ischemia, or endoleaks. And thus, it appears to be a safe and effective device for treating thoracoabdominal aortic aneurysms, once again, advancing the seal zone cephalad. A complementary device by another company, which is Cook Medical, which is T-branch off-the-shelf stent graft, which can be used for elective, urgent, and emergent cases of thoracoabdominal aneurysms. 100 consecutive patients, elective, urgent, emergent cases are included. Interestingly, with this study, all patients were treated transfemoral, so upper extremity brachioradial axillary subclavian access was not needed. From the femoral approach, they had 97% technical success and a 30 mortality of 7%. And again, this was elective, urgent, and emergent patients included in their study. So these are alternative means for which the direction of endovascular therapy is going. But all of us will acknowledge and recognize the following. Adverse events happen intraoperatively. And this is one of the few studies that you're going to see talking about not just good, but also bad outcomes. And with that being the case, they had 600 consecutive patients who underwent fenestrated and branched EVAR, single institution, 12 years, high technical success. Interestingly, 18% had intraoperative adverse events that were significant. 9% of those were target artery vessels and 8% related to the access site. Predictors based on their multivariate regression analysis included female gender because of smaller access vessels, existing target artery stenosis primarily within the renals, and extent type 2 thoracoabdominal aneurysms. So in summary, I think what we can say in a 2 to 3 decade period that EVAR continues to evolve at a rapid pace. It appears to be the preferred treatment for elective and emergent aortic aneurysm repair if anatomically suitable. Improvements in device design, technology, planning, increased physician experience really have reduced adverse events and made more patients eligible for endovascular repair. The last few slides representing fenestrated and branch devices really have expanded indications for repair, and I think due to the fact that we're able to advance the seal zone cephalad, we've lowered the adverse event rate of type 1 endoleaks and need for future intervention. Thank you.